Greetings, everyone. Welcome to the Two Bad Nurses podcast. My name is Yomi Richardson. I am going to be the host for this podcast.
I'm Lisa Heath, and I'm co-hosting with Yomi.
Yay. So, girl, what's up? We're doing it.
I know.
Oh, my goodness.
Yep, I'm ready.
I'm telling you. So, we've been talking about this for a little bit over a year doing this nursing podcast. And so here we are. Do you remember when I sent you the text saying,
Yes.
Lisa, you want to do a podcast?
Yes.
What was your thoughts? What was your thoughts when I said it?
I thought, what a great idea to be able to talk about the things that us nurses talk about that maybe we don't want to say, in public, but we're talking about it in the break room. And so those are the kind of things that I think are kind of interesting, and, to get everybody's feedback on it and, just see what everyone's opinions are, because there's so much going on in the medical field right now.
It is. Have you been, not a silly question, but had you been up on podcasts before I brought it up, or?
Not really. I've seen a couple, but I really wasn't familiar with what they were.
Okay. When I thought about it, the podcast space, it's growing. And so it's a lot of people that's jumping in, and it's like everybody has a voice. So when I thought about it and I was looking at some of the other podcasts that are out there, it's like, I feel like we have a niche in terms of our longevity in nursing. We still look young, we still look good. And so when other podcasters that I was listening to, were like, they had tried to reach out to their colleagues, some experienced nurses, to say like, hey, come on this podcast. I want to start this podcast. Let's talk about, your longevity, your experience in healthcare. But the nurses were like old and set in their ways. And they're like, no, we didn't want to do it. And so I'm like, no, we're young, you and I. We're young. We should be able to share our experience with the next generation. And I think because we're uniquely positioned, having been graduate nurses at the age of 22 and starting a career and having such longevity. So that's what I felt like, hey, why don't we do it? Let's get the game.
Right. Because, we're kind of in that age group where we're young enough to still do it, but old enough to have been around enough to give some good advice.
Exactly.
I've got the nursing experience, and I think that all of the nurses that we've worked with, over the years have taught us so many things. And now we're seeing after the pandemic and all of the new nurses starting, how much there's a need to have nurses just out here talking about real things and helping the newer nurses.
Yeah, definitely. So speaking of real things, the name Two Bad Nurses. So as I was sharing with you, like when our respective significant others at the time, they were into rap music. And when, when Courtney would drop me off at Truman, he would say, Two Bad Nurses would be playing on Adrenaline Rush. And he would say, the rap went, I'm bringing the pain like two bad nurses. And Courtney said, that's you and Lisa. We good nurses. We're not bad. We know what we're doing. But that's where the ideal of the Two Bad Nurses came up with. And again, because we're young, we know what's going on in the culture. We're not outdated. So to speak. I felt like bringing in, even introducing Twista and Adrenaline Rush, as our theme song. And, the young kids, nowadays they hear things and see like Missy and, oh, she's going to be hot one day.
Right.
Not knowing that, hey, Missy's got a career.
Right.
So definitely where the Two Bad Nurses ideal came up with. And then again, just kind of merging our experience, like you said, that we've had in our respective professions. And it's been very diverse, as we'll talk about. And then also too, because we are still young, we're tuned into the culture, and we can help guide nurses into this kind of, because the more things change, the more things stay the same. It's really nothing new under the sun. And so as you mentioned, the pandemic, like we have experience and expertise, and bringing in the culture as well, because as we know with social media and how it's increasing, the culture is absolutely intersecting with healthcare.
Absolutely.
Yeah. So jumping right into it, just as an introduction, introduce yourself. Why did you become a nurse? What do you
do? So I actually never really dreamed of being a nurse, all my life. It wasn't like a life goal. I did get pregnant, yeah, at a young age, at 18, and I had to think of a career that I could do that would help me provide for my daughter as a single mother, and something that would be interesting. And I had a lot of family members in the healthcare field that guided me, and nursing became my choice.
Mhm.
Um, my first job out of nursing school is where I met Yomi. We were both at a hospital working on a telemetry unit, and we both had goals of working in the ICU. So we started in telemetry unit, and then we transferred to an ICU, and became our career, began our careers there. And from then on, I've gone and done community healthcare. I've done prenatal case management, and currently I manage a hospice patient care team. So that's what I've been doing for the past 20 years, is end of life care.
Mhm.
Yeah.
So yeah, we definitely met at Truman, and I think that's the only hospital that we're going to be able to name drop if I've done
Oh,
my research correctly, because we're not
oops.
current employees. Did you mention the names of your
Did
hospital?
I? I don't think I did. Did I?
I think you did either.
Did I? Oh
No,
my goodness. We'll have to watch this back.
we'll clip it out.
Yes. Edit.
I don't think you did. I know, right, Edit?
Okay.
But yeah, we met at Truman, and just like
You
you,
just did? Oh,
I'm not going to say the current employer.
yeah, right.
Yes, but like nursing was not my first profession either. And it's funny because you see nurses, and some nurses will say, "Oh, it's what I always wanted to be." Like my mom was a nurse, and she was the one similar to you. I was a teen mom, and mommy was like, "You need to go down there to Penn Valley Community College and get this associate degree so you can take care of your child." But I knew nursing wasn't a profession that you just jumped into. Like it's
Mhm.
people at the end of this, and the work that
Right.
you're doing, people is our end point. So I was like, okay, I'll start, but if I don't like it, I'm going to go be a lawyer, because that's what I wanted to be. And I
Mhm.
found that I love critical care. And so when we were going through nursing school, and when we graduated and started at Truman, at that time, remember, we all started on nights as new grads. Nobody immediately jumped into the ICU orientation program. We didn't
Right.
have that. So we did 1 year on telemetry, 5 red. And then from there, we transitioned into critical care. And for me, I've spent the next 15 and a half years of my career in some form of critical care, ER, ICU, dialysis. Even when I relocated to the state that I'm in now, I continue with dialysis and work for the current health system as a case manager, which is a very unique role. So, but again, we'll kind of get more into that. But yeah, so what would you say is kind of your soapbox issue in nursing?
I would say,
Yeah.
I'd say now, right now, there's a lot of political things, political viewpoints that are coming into the nursing field
Mhm.
lately, and it began really with the pandemic, strong beliefs about vaccinations, non-vaccinations, and things like that. And sometimes, where I feel in the past, we just really left politics out of it. We just kind of came to work, took care of patients. I mean, most of the time that we worked in ICU, we didn't even know what type of insurance a patient would have, because
Right.
we just took care of them, we didn't
Mhm.
know. And now there's lots of Republican, Democrat, different, viewpoints, and there's more cliques
Mhm.
of people that kind of hang together. And nursing's always been a little cliquish, where you have the night shift against the day shift, or the ER against the ICU. And you had your little group but I feel like lately it's become a little bit intense
Definitely.
more
And
intense.
personal too,
Yes.
where people personally, and definitely when we began our career, and Truman is such a staple in my nursing practice to this day. And how we were oriented, the experiences that we had, and having an IV pole, no IV fluids, no tubing, your vanc is coming up on the lift, but 2 hours later, it never arrived. Like And then even the accountability that we had amongst colleagues, like we just couldn't come and tell the day shift anything. Like if
Right.
potassium was out of range, it was like, well, what did you do about it? Who did you call? Where did you go? So even though it was that professional accountability, we still kind of left. I felt like I didn't know that nurses didn't like each other, our colleagues didn't like each other until we got to the break room. But it was like on the unit, and everybody's just kind of eating their food, not paying attention to one another. But on the unit, we were cohesive and we worked together. But with this whole, I think it's Trump activated a different, he activated something in the culture to where it's now, and even out here in California, to where it's like people are attacking people. And even in healthcare, people are attacking people in viewpoints. And as a case manager, when I'm going to the bedside to talk to somebody, like I'm getting a whole spew on immigrants,
Yep. Yep.
migrant workers,
Uh-huh.
the economy. And I'm like, I just came to verify your address, sir, and actually home health. Like, and just these, and another point, girl, people are very just dogmatic. They're not willing to relinquish on any perspective. It's like, I believe this, and that's law.
Yeah, absolutely.
Mm-hmm.
And you see some nurses that, what I notice is some nurses that were very close. We've worked together for 10, 15 years, close. Over the past few years, that friendship's gone away. I mean, you see, I don't know if you ever get on that Nextdoor app or if you have that.
Had to
It's
come out.
okay. Have you seen some of the Nextdoor people like, Lucy, don't you ever come over here again? We're done being friends. I mean, friendships ending over what their viewpoints are.
Mm-hmm.
And I've got 20 nurses on my team, totally all from different walks of life. And some that started off close are no longer close because of political views.
Mm-hmm.
So, I mean, they've just become a lot stronger. People are really standing on, there's no listening or trying to compromise or understanding
Mm-hmm.
how another person might feel a certain way, which I've always felt like I'm pretty open-minded and I've kept my cool kind of through the whole thing. I think you and I both kind of, that's
Mm-hmm.
something we've always had in common. We may have differences of opinion on something, but we just kind of,
Mm-hmm.
I can understand that.
And let
So,
people be people,
right.
and it's like now there's not even that desire to do that. So with nursing, we definitely hear about the threats in nursing in terms of education. There's not enough of a nursing supply. And I still hear, so we graduated in 1996, correct? From
Yep.
December 96.
Yep.
I still hear today from nurses, like they're having a hard time getting into nursing school and they're waiting 4 or 5 years to get in. So with these threats that we have in nursing, and also once they're getting on the unit, like the culture of nursing has changed because it's no longer like the nurses that oriented us and had been on the unit for 20 plus years, and some of those nurses on the floor had been, on those colored floors, they had been 30 years on the same unit. But I feel like that's a dying breed of nursing
It is.
that I don't see too much around. And
Yeah. Now a nurse that's been a nurse for about 6 months is training you when you get out of school.
how do you
Or
feel about
a
that?
year. Eh, I mean, you got to do what you got to do, I guess. When there's a nursing shortage, what do they say? Learn one, do one, teach one, or something like that. I mean, but it's rough. It's much better the way it was when we were being trained because you trusted those nurses, knew what they were doing, and you felt confident that when you were dealing with people that were critically ill, that you had people there to back you up that knew what they were doing. And now it's a little scary to think that somebody that just became a nurse is training you and hope that they've experienced whatever situation that you're going through and can really be there to show you the right way to do it.
Yeah, that was definitely an issue when I relocated to California. I felt like every area of nursing that I was transitioning to, like I was just kind of being thrown into it, so to speak. So with dialysis, definitely, I had given them notice to say like, hey, I'm coming out here. this can be my start date, but I'm willing to orient for this time. So that way when I start, I can just kind of jump in. And it's like they just wanted to show you. It was a new machine, CRT, which I hadn't done. And literally I had to learn that just kind of on the job. And I was always having to, say, this is a hard stop. Like, this is the line in the sand. Like, I can't be out here checking CRT machines and only knowing, the mechanics of it, but not fully understand what is this therapy for and how does it play into kind of the hemodynamics of what's going on with the patient.
Right.
And even at that new training that to this CRT, balloon pumps, it was like, what are we doing here? It was just like a check off. Somebody's done it 3 days, and then on day 4, they're now training somebody else, or the following week.
Yeah.
I'm like,
scary. It's kind of scary.
I think it's very scary.
Yeah.
But I don't know that there's an answer to that. I don't know that there's a solution to that.
Until the nursing field is back to where it was, I mean, all these new nurses now, because there's a nursing shortage. I mean, well, it's going to start with paying nurses what they should be making, and having it be a more attractive field for people to go into. And then maybe you won't have the nursing shortage. And then from there, you'll have enough nurses to train, other nurses, and nurses won't leave, and they'll be there for 20 years, they'll be there. And, kind of like the same way that when we started, I know a lot of the nurses, they had like the weekend option programs with bonuses and all that. And that, a lot of that went away. I think it's starting to come back now because there's a shortage. But those nurses that had those bonuses or those programs, they didn't leave. They didn't leave because they had it good. And then over the years, when things changed and they took away a lot of those things, now it's just now coming back. So I feel like it'll be maybe the next few years, we'll start seeing things kind of go back to the way they were when we began. I hope.
Do you think it will?
Well, I hope if they pay the nurses what they should, because that's the bottom line. The younger generation right now, there are so many avenues that they can make money. They social influencing. I mean, there's all kinds of things that they can do. And they're like, why would we work this hard? Why would we pull a 12-hour shift, work holidays, do this, do that, if we're not being compensated in the right way? I mean, I remember how much you and I made when we first started. And I mean, I'm like,
$13.75. $13.75. That's what we made. Yeah.
15.20 with the shift differential.
I'm telling you. Because Courtney was like, y'all could go work at Lipton Tea. Why did y'all get this? Why did y'all spend this time in school? Like, the people in Lipton Tea are making more than what you're doing.
That's what I'm saying. And now I think my daughter's making that, like, serving at a restaurant. You know what I mean? Like, nursing has never, and I mean, now, things have changed and they're being paid more now, but it never is keeping up with the actual salaries that everyone else is making for that current time. You know what I mean? I feel like they really do need to pay nurses and teachers, more. So we don't even want to go on that, but
no, that's going to come in future episodes.
Yeah.
But definitely, like nurses or like teachers, I'm a little bit more skeptical because the business of healthcare, and you know that intimately in the work that you do, and then myself as well, dealing with the insurance, but the business of healthcare and how they view the work that nurses do. They know that we're indispensable within the system. Like, you can't have healthcare without a nurse being present. But I feel like the wages that we either get or ask for are so offensive, and it's seen as just kind of lost money that's going down the drain. We know we need you. We can't do healthcare without you, but we're paying you so much money. And kind of case in point is, as a registered nurse under my current role, the wages are not on par with CNA, which is the big California Nurses Association out here.
Okay.
So we're under a different union, and it's a significant, it's a significant difference in what it is that we're making. So it's a way of keeping wages stagnant. among nurses. So that business part of healthcare just really has me skeptical in terms of what the future will look like for us.
Yeah, well, at least you have a union.
True.
Not all of us have that. So, I mean, we'll see. I just hope that I don't know. I don't know if it's a change in administration or what's going to happen, changes with, healthcare, depending on who's in the Oval Office, what are we going to do about healthcare? And so it's hard to even answer because that changes every, 4 years.
Yeah.
So we don't know. I mean, it could go from the healthcare is a high priority, and then 4 years later, it's at the bottom of the barrel. We don't know, so it's hard to say, but I know that nursing is a real important career. I think there's a need, and I wish out of all my 4 daughters, even one of them would have done it, but not so lucky.
Yeah, none of my children wanted to be nurses. Rachel tell you in a minute, she'll say, no, you just don't jump into nursing.
No. And they saw how hard we worked and what they saw that we were gone all the time, working all the times. And
Right.
now they're like, oh, I'll just go on TikTok and make some videos or something.
Definitely with this generation and the social media and technology, people in general, they're tapping into it to see, like, nobody's tied down anymore. We were talking about this, like, everybody is looking for different ways to monetize whatever it is that they're doing. I'm not mad at it. We're doing it.
No. And there's so much remote work out there now.
Exactly.
Like, why would I even go into the office for what? So it's bedside nursing. They're going to have to get creative to get nurses in that hospital because there are lots of remote jobs for nurses.
Yes. And then also too, what I would say is, like, the workforce, like for us is we're Generation Z, right? Gen X.
I think we're Gen X.
Gen
right?
X. Yes, I should know this. Absolutely. Always name dropping it. But when you look at the different generations, baby boomers, Gen X, the millennials, these younger people, they're not staying at the bedside for, even 5 or, 10 years. And I would say to my colleagues, you have to look at who we're hiring. What are their goals? Are they in school? If they're not in school, just kind of what are their goals? And you may be able to get between 2 to 5 years out of this employee, a new hire that you're bringing on, even if it's an internal transfer. So from that perspective, how do we optimize the work that person does, but then to where they still feel nourished and don't feel, taken advantage of? It's a skill, and you have to look at these different generations because these kids, they're not staying at the bedside, for decades in a unit.
Yeah, and why should they when they have all these other options? There's really no reason to. If you're bedside nursing used to be where you would get paid the most, inpatient hospital. Now you can make that other places. So there's no incentive.
Right.
There's no incentive. So we have to be real creative about incentives. And that's one of the things as a manager that I'm always talking to upper administration about. What incentives are we going to give? We have nurses that you want working night shift. We need to give incentives. We want to, there's got to be perks involved because there's just too many other jobs out there that they can go to and work less, make the same or even more. And so I'm real big about that. And I feel like that has got me to a point where I've been in this same role for the past 20 years, because that's the way I think. And I feel like you have to think like that to be successful.
And what you're saying is like reminded me as when we go up the ladder as managers, executive level leadership, really kind of being committed to advocating for our staff. Like we get, there are people, they're lateral colleagues one day, they're our supervisor the next day, and they're drinking the Kool-Aid, sending us out these pre-printed emails. And it's like, you was just doing what I was doing a couple of months ago. They start losing sight of what it is to, work as a lateral colleague or closer to the ground. And when we're talking about just wages and the conditions under which nurses are working, like staffing, having the equipment, break relief nurses, it really takes our managerial and executive level leaders to keep that foremost, when you're bringing that back within, these other people that are business people,
Yes.
within the organization, but to say, no, this is needed for nurses and the work that we do. So to really stay connected to nurses, that's definitely an important point.
Yeah, there has to be a balance. There has to be a balance with nursing, the medical, the clinical side, and the business side. You have to have a business side, of course, to, stay afloat, but you have to have the clinical side to even do the work, to even, get farther. I mean, you cannot have a hospital, any kind of a healthcare organization without healthcare workers. So they have to be, at the top of the list, and providing the incentives and making it a place that they want to stay, and being there and supporting them, and those perks and those benefits and all of those things are what's going to get you the long time employees that are going to do their best, and they're going to be completely engaged in what they're doing.
Exactly. And quality, especially with reimbursement being based on quality metrics, that definitely factors into it. But okay, well, as we kind of wind down a little bit, I got a question to ask you.
Okay.
Care, is it a right?
Healthcare?
A right?
I would say yes.
It is.
Yes.
I'd agree with you. That was a question that we asked each other. Is it a right or a privilege? I think that's.
Oh, I definitely don't think it's a privilege. I think it's a right for people to be able to live. My goodness. Okay.
Exactly. To be able, I'm telling you, some people see it as a privilege.
Really? Really? They see it as a privilege to be able to just live?
I'm telling you, live and be healthy and have insurance. No, I
Okay.
agree with you. It's definitely a right. And I feel like it's a right that as a nation, we should be investing in on all levels, federal, state, and local. We should be investing into how do we keep people healthy?
Right.
Because it's going to benefit all of us.
Right. And doing it the right way to where our healthcare isn't lacking. It's not getting worse because we're providing more of it.
Yeah.
We've got to figure out that part.
Yeah. And definitely it'll take a nurse, like for our voices to be amplified within what you had mentioned in terms of the White House earlier, like how nurses show up in these spaces, the political activism of nurses to be able to advocate for our own role, our own voice. It's like nurses see the future. Out of all the healthcare team members, it's like nurses see the future. I mean, because remember how we would have to rig stuff.
Yes.
Over our career, but we got it done.
Yep.
We got it done. So it definitely takes a nurse. So last question. Are you happy that you became a nurse? If you could go back 26 years, would you change or would you?
Oh, I'm totally happy about it now, where I am now.
Yeah.
There were times where I was in jobs that I didn't know so much, but definitely where I'm at now is where I need to be.
Okay, I agree with you. We both said, motherhood was to become nurses, but I'm definitely glad that I got into this profession because like we play such a key role. Nurses make or break everything within the healthcare system. And so, even your doctor, remember 1,000 milliequivalents of KCl? And we were looking 1,000 or 10. That 3 o'clock order, 1,000 or 10 milli, equivalents of KCl. So it takes a nurse to come in and do that. So let's get into the first topic of our podcast. And unfortunately, it's a sad one, but definitely as nurses, we have to delve into it because, of course, we work everywhere within the healthcare organization, and surgical sites, whether inpatient or outpatient, are no exception. But what's trending now in the news, unfortunately, is the death of Jacky, this beautiful young woman that at the age of 32 went in for a mommy makeover. And we'll get into the details of what that is in a minute. But she went in for a mommy makeover with a surgeon, a well-known plastic surgeon. And unfortunately, she died. Now, the details that are surrounding what happened post-operatively are kind of unfolding from what we've been seeing on social media. And I think we're both in the same boat with this as nurses. When we see things definitely in healthcare that are being reported in social media, we're looking at it through our nursing lens. And, our first reaction is like, okay, I need to hear more. What was going on with the scenario? How was she being monitored? even preventatively, like what kind of screening went into her before she had surgery. So we always want to know more. So just because people report things on social media, as nurses, we don't, just run with it. We definitely have to know more. But clearly something happened to where this young lady has passed. And just what are your thoughts on plastic surgery when you heard what happened? Like, what was your initial reaction to this passing?
I mean, initially I was very saddened that it happened. And my thoughts on plastic surgery basically are, I've always been for any kind of plastic surgery anybody wants to have, anybody that wants to do anything that helps them feel better about themselves, go for it. If it's safe, if you're healthy, if you've been screened, if you have a heart problem and your cardiologist cleared you, if you have a neurological problem and your neuro cleared you, do it if it's safe. But if it's not safe, I don't think it's worth your health to look a certain way. Now with in her case, I really don't have the details on what happened and what her screening was like, what her, obviously she was stable enough to be discharged to the hotel.
Mhm.
So I don't really know enough. And I think it'll come out, in the next days to weeks of, some details of what happened, and we can maybe weigh in further, but right now I don't know enough about what actually happened that caused her to pass.
Yeah, that's true. And I think if we kind of start with what we do know. So first we have a young woman, 32 years of age. We don't know her past medical history. And for those people, our viewers that are listening, when we're talking about preventative health care and those factors that a doctor considers before any kind of elective procedure, which may be what's, definitely got people in an uproar. It's like, she didn't have to do this. You didn't have to go, get this done because it's an elective procedure. Your life wasn't, in jeopardy, to have this done. But when we're looking at preventative health care, one, is the patient established with a primary care doctor? Do they have what's called comorbid conditions or conditions like diabetes or high blood pressure that could complicate either your wound healing or that post-operative course and how you recover? And for her being, so we don't have that information like you noted, but with her being a 32-year-old woman, we can assume that the fact that the doctor took her in to perform the operation, that she had a level of health that, he felt that she would survive the procedure.
Right. Yeah, that's true.
Mm-hmm.
That's true.
And what I also think about it too is, what's been coming up with this doctor, Dr. Zach. I'm not really familiar with him, but what she went in for before we get on him was a mommy makeover. And you were saying the components of the mommy makeover are
The breast augmentation, tummy tuck, and sometimes a Brazilian butt lift.
mm-hmm.
So I'm not sure
What
which ones, that she had, but probably the tummy tuck and the breast augmentation, I would think for sure.
Yeah, and I think she was already had an augmentation, it looked like from some of her previous pictures. But when we have children, and whether we nurse children or not, the breasts can sag, even with an implant in. It's still breast tissue that's covering the implant, even if it's under the muscle or over the muscle. The surgeons will tell you that if it's under the muscle, the less potential that you have for sagging, but it still happens, and especially with multiple births. And she had 3 young children.
Yes.
So either it looks like she already had an augmentation, but a lift may have been part of that, and then liposuction too. And then it kind of segue off in a little bit into that Brazilian butt lift. Like, what have you been hearing about the BBLs?
I hear that it's real popular. That's all I hear about. Like the younger, my neighbor, like everybody will say, "Hey, did you see so and so's?" But like, it's really popular.
Yeah.
And even with different cultures, remember back in the day, I don't know, when I was in high school, like the, European, just, white people that were nice cheerleaders, blonde, they wanted absolutely no butts at all.
Right.
No butts at all. And now it's like everybody wants a butt.
Yeah. And remember the implants that people
Yes.
were doing? That's
Yes.
never understood.
Yeah, no. And then remember, some people were getting injections and they turned out to be like injecting cement or so. You remember like these rumors that they had. So I mean, I think if it's a safe procedure that they can do and give people the butt they want and they want to do it and they've got the money to do it, go for it.
Yeah, but that, what you said there, safe.
Yeah.
And part of that
If it's
safety.
if it's safe, but it's just so ironic to me how it came from. Remember back in the day when people would say like, oh my gosh, does this make my butt look big?
Yeah,
And now they're like, it does. Oh, that's a good thing.
yeah, they
Yeah,
wanted with
yeah.
that BBL, because I actually follow plastic surgery a lot, and a lot
Mhm.
of the physicians. So you've had like Dr. 90210, Dr. Terry DeBro and Paul Nassif. They do one on E. I can't think of the name
Mhm.
of the show.
Yeah,
They
I
do
don't
one on
remember the
E.
name.
And I think just in thinking about just kind of plastic surgery and the stigma, I feel like there is a stigma a little bit attached with plastic surgery. So when you tell people that, hey, I want to go in for a mommy makeover, I'm considering having this elective procedure, I find that people respond, well, why would you want to do that? What would you, what are you going for? You're fine, you'll be okay. Part of how in the culture, like with the Dr. DeBro in his show,
Mhm.
comes on E, they show people with genuine concerns, men and women,
Is that botched? Is it called
botched.
botched?
Thank
Okay.
you. Yes, botched. They show people with legitimate concerns having, very relevant procedures, but then, they bring these people that are just anomalies and are making themselves look like a character. And so
Mhm.
when, the big, huge breasts, the big, huge lips, the butts just are deforming themselves. And somehow that becomes conflated with plastic surgery, and when we see even the BBLs that are not done. They have what's called now a small BBL, to where it's more natural looking and it's not that, that big protrusion, that irregular protrusion. But with that having been so popular in the culture, these big BBLs and these big, huge breasts of the 90s, and the complication, remember Jenny Jones?
Yes. Yes. Until you just mentioned her name, I totally forgot she existed, but she was we had to watch her every day back then.
You had to, but her soapbox was on implants
Yeah.
and how not to get implants. And that was definitely her experience. And,
Mhm.
she should absolutely share her experiences as a cautionary tale for other people. But
Yeah.
for somebody like, Jacky O that had this procedure done, and what people may not readily realize is that, it's another one, Monique Slaughter, that's been trending as well, that hers has been on Instagram, and she was actually saying that she canceled her procedure because of what was happening, the backlash that she was receiving, but that her abdominal muscles had actually separated
Mm-hmm.
diastasis rectus, so a separation of those muscles. And so no amount of sit-ups, no matter how you hit it, it's not going to bring those muscles back together. The surgeon has to actually come and loop it in. And
Right.
so, but that gets lost, and especially when we have these untimely deaths and these destination surgeries that are happening.
Yes. Yes. That the destination surgeries are what's scary to me. Um, you just don't know. I mean, you're not in your own country. You're not with your doctors able to, weigh in your primary care, your physicians. You're in a whole nother country and you're just hoping that the things that you've read online or wherever you research the doctor is all true and it's a safe, clean place that you're going to. Um, I know plenty of people that have done it and they love it and they said it's great. And then you hear horror stories too. So you just have to, I think, really do your research. And it for me, I would not want to do anything in the States, even if it saved me a few $1,000s. I would not want to leave the United States just because I would want I would want to know like that I have follow-up afterwards if I had complications. So I come home 6 weeks later, I'm having what looks like an infection. Am I going to go to another doctor here in the States and are they going to even touch me? Because this was a doctor from Mexico who's going to call me in an antibiotic if I need it or Those are the types of things that I would think about.
And that's an excellent point. And this is why this podcast is so necessary to get that information out to people, because I don't think that these are things that people think about. And again, I follow it, like Hazel Lee is another celebrity that's been very open about having cosmetic procedures done internationally and how she's been affected, the complications that she's had. And that point that you made is a really good point, because even with surgeons, which we know as nurses, surgeons do not want to come behind the work of other surgeons. They will, elective procedure or something that you've done, they're going to send you back. So you may come to one hospital thinking that, oh, they're going to fix and repair. Absolutely not. They're going to send you back to that physician who operated on you, unless they're a reconstructive surgeon like botched.
Right.
This is the work they do, and they know they're going in.
And that's going to cost you a lot.
And that's going to cost you a lot. Exactly. So it's best to do it right at the beginning. And I'm not a fan. I don't support the tourism surgery because, one, we don't know the standards that go into it. I feel like you have things done where the game is being played. And even here in our nation, United States, like California, Florida, New York, these are the states where people flock to have plastic surgery. And just
Miami.
Exactly, by volume, these clinics and these physicians, they're used to dealing with, the volume and the complexity of patients and the differences in how patients present. So with you being there in the Midwest, I would even be a little bit hesitant. I'd have to, how long have you been doing this? Because culturally, geographically, from the culture, it may not be as prevalent as it is for somebody like me in California.
Yeah. That's true. I mean, I wouldn't mind going to California to get surgery, and just like the hospital that we worked at when we first started, the trauma center, level 1 trauma center, everyone knew if you got shot, come there.
Yeah.
If you have a heart problem, don't come here.
Exactly.
Because this is what we do. We do traumas,
Exactly.
So you want to go to where they do it all the time.
Yeah, definitely. That's a very good point. And the other part of that is you mentioned the recovery, and again, just being able to, your physician to call you in antibiotics, and to be seen sequentially after you have surgery. Physicians with drug resistance, how hard is an antibiotic? And now you think you had something done in Mexico when you come into the ER, here in the States, and somebody's just going to prescribe you. It's like, what's going on? But the second part of that, we should talk about, is that board certification. So just even a cursory search shows that board certification is education beyond minimum standards. So when we think of your physician being a fellow, when they say that they're a fellow, they're receiving additional training in whatever their specialty is. ENT, ear, nose, and throat, GI, cosmetic surgery. And so even with cosmetic surgery, it's just not, one physician is a physician for all. If somebody specializes in noses or craniofacial, something that's going on with your face, I don't know that I necessarily want him or her on my breast or do my tummy tuck, because that's not what they do. Even the lipo.
Right. That's like you said, for board certification, you have to do continuing education. You have to be up on the latest things on that field. And I just would want someone who is an expert all the way around.
An expert, definitely.
At whatever part of the body I'm working on, if you can be an expert on that, that would be loved. Yeah. I would not want anything else. Yeah. So, and those are things you have to look at when it comes to cost too. People, you want the best, you're going to pay more. If you're getting something done in a different country that sounds too good to be true, it just might be.
Yeah. And that's just not a cliche. That's facts. And any plastic surgeon that's, kind of worth their weight, they will tell you, any doctor, but they'll definitely tell you, like, even with LASIK, I waited decades for this procedure to be out before I, laid and had my eyes done. But they'll tell you, like, investigate and see what's going on with your physician. And the other part of that is, where do they have privileges? So when we're talking about our doctors, what health systems are they connected to? If they're operating out of a clinic, that would be okay if you're telling me that you're connected to UCLA, Cedars, or USC, Tech USC.
Right.
That would be okay. But if you're telling me that you're operating out of this clinic and God forbid something happens to me, which ER do I go to? Where do you have privileges? And you don't. That's a problem.
Right. And that's a question not people that are not in the healthcare field aren't going to know to ask that.
Right.
So it's really important, that I think for nurses and those of us that have family members, just to get that education out there to people, because if you do not know about the healthcare field, it will never come to your mind to ask this doctor which hospital he has privileges at. People don't even know that the doctor has to have privileges to go to a hospital. They don't know that.
And what are privileges?
Exactly. What are privileges?
Yeah. So to even ask that, they would.
Yeah.
But just if something happens to me, where do I go?
Yeah.
And can they call you?
Right. Right. And people sometimes think I'll just go to the closest ER. They don't think about, where is the best place for me to go. I mean, and which hospital will touch you after this doctor, or you know what I mean? Like, if they have them. I mean, I just did my eyebrows. I had my eyebrows microbladed in Warrensburg, which, is a little town out. And I couldn't find anyone in Kansas City when it was time to do the retouch. I couldn't find, they were like, if I didn't do it, I ended up having to finally search and find someone in Lee Summit who was willing to. She said, but you got to send me a picture. If your eyebrows were going to be, if they were jacked up, I wasn't going to touch them. The only reason I'm doing them is because they look okay. So, but she did my retouch, and now I've got someone local that can do it. But I was going 3 years with no retouch because no one would touch me, because it was in a little town outside of here, and I wasn't going to drive all the way back there.
Yeah. And see, this is
and that's just eyebrows.
That's eyebrows. That's just eyebrows. This is what I want people to hear, is that message. Like, these are factors that go into, when you're making that decision for cosmetic surgery. And whether it's a mommy makeover, a Brazilian butt lift, like, what are the complications? And definitely as nurses, we see things differently. And our thing is like, okay, what's going to kill us first, or what's going to kill the patient first? That's how we think. But you should be thinking that way. Like, what complication could kill me? And am I healthy enough? And part of that preventative care, because again, Kanye West's mom and her surgeon was I followed him for decades, Dr. Jan Adams. And he was on Plastic Surgery Before and After, I believe was his show, and he was featured on Oprah. So very credible doctor, but things happen. Things can happen, and they're called, these accidents or unforeseen for a reason. Right. But it's things that you have to consider, and you have to ask yourself to weigh, like when you're considering this, any kind of surgical procedure, and especially going under, the difference, if you want to explain, between general anesthesia and like local.
Yeah. So general anesthesia is when you're actually, the gases are used and you're put all the way under, and they're breathing for you with a mechanical ventilator, or bagging you. The anesthesiologist is helping you breathe. Local anesthetic is when you just have numbing around the area to where you don't feel it. And then there's conscious sedation, where basically you take a little nap, which is like Versed, fentanyl, propofol. So we just, those are all different types of sedation, and you breathe on your own on those. So those are the 3 different types.
Yeah. And those are things like, to, again, do your research.
Yes.
Any kind of procedure that you're considering, like, don't just jump into it. And you think that, I have to have it now, but it's best to wait. Best to wait. Do your research. Maybe ask your physician, hey, can you give me some patients that have had, procedures done with you? Definitely let me look at pictures. Can I talk to somebody to see what their experience is? Because it's a holistic experience. So it's not just the procedure, go recover somewhere, go home, but what kind of post-operative monitoring, and even how available are you after the procedure? In case I have complications, some doctors give out their cell phone numbers to their patients. because they want to be that accessible. So these are definitely questions to be asking.
Absolutely. Absolutely.
Okay. Well, thank you all for tuning in to our first episode, and keep tuning in to Two Bad Nurses because we got more topics to talk about.
All right. Goodbye, everyone.
Thanks. Bye.